Thank you, Dr. Goldenberg. So today's round is on the surgical management of high-risk prostate cancer. As we so often hear, prostate cancer is a spectrum of disease from very low risk, where the number needed to treat is 50 to 100 patients, way up into high-risk disease, where many men, in fact, die of their disease despite treatment. And the current treatment paradigm is shown here. Surrogate PSA screening is done on most men, and this identifies a large number of low-risk cases and a smaller number of higher-risk cases. And we all know about stage migration, which has occurred over the past 20 years with PSA screening. Most of the cases detected these days are T1C cases and in the low-risk category. Most of the low-risk cases get treated. And this probably represents over-treatment for most of these men, both in terms of any treatment at all, treatment intensity, and the functional outcomes and impairments which result from treating prostate cancer with contemporary treatment. Not surprisingly, most of these men do very well with treatment in terms of oncologic outcome. For the high-risk cases, it's a different story. Contemporary treatment relatively undertreats high-risk disease, and most of these men do quite poorly. And this creates a self-fulfilling prophecy amongst the professionals treating prostate cancer, which tends to make us think that treating low-risk disease is good and we should be doing that, but maybe we should shy away from high-risk disease because most of these men do poorly anyway. So we know that the outcomes for low-risk disease are good, but not so good for high-risk disease. So how can we improve this? Well, better identification of high-risk disease is important, and multimodal treatment strategies are going to be how we address the poor outcomes for high-risk disease presently. Improving identification of high-risk disease. Currently, sure. Turn me up a little bit. I'm sorry, I'm recovering from a cold, so I sound like a frog. Can you hear me now? Yeah, good. Okay. So currently we identify high-risk disease based on three features: biopsy features, the Gleason score, and the fractional core involvement as a reflection of tumour volume, the PSA at diagnosis and PSA kinetics, and the digital rectal examination. And in the future, genetic factors will allow us to characterise disease so that we can ascertain the threat of the disease to the patient. Anthony D'Amico performed a retrospective study of 1,453 men who underwent either radiotherapy or radical prostatectomy for T1C and T2 disease. And these patients had a median follow-up of 4.5 years. And not surprisingly, he identified PSA, biopsy Gleason score, and clinical stage as having a significant effect on prostate cancer-specific mortality as those numbers and scores rose. The interesting feature of this study was that PSA velocity was found to be an independent variable which predicted for mortality from prostate cancer. So in the year before a diagnosis of prostate cancer, if the PSA velocity exceeded 2 nanograms per mil, the patients in fact adopted the risk profile of the high-risk group, even if their other features were that of low-risk disease. And this is a graph showing the death from prostate cancer for that group with greater than 2 nanograms per mil per year. So the curve is quite steep, and these patients clearly have a poor outcome. And that PSA velocity is correlated with adverse pathological features and, as I've said, a high death rate. So he recommended that PSA velocity should be considered in otherwise low-risk disease as a high-risk feature, and these patients should probably not be considered for active surveillance protocols, and they're possibly candidates for enrolment in clinical trials of adjuvant or neoadjuvant therapy plus radical prostatectomy. Digital rectal examination is the least precisely assessed preoperative determinant of disease risk, and this is shown by Alan Parton in a paper published in the Journal of Urology over a decade ago, where he assessed 565 men personally, and then after the surgery, one pathologist examined the specimens. When the DRE suggested T2 disease, about half of men were in fact pathological stage T3, and when the DRE suggested T3 disease, 1 in 5 men were in fact pathological stage T2. Now this data is interesting. We probably know that DRE is not that good already. More recently there's been stage migration within the high-risk group, so that we're seeing less men with T3 disease, and more of the high-risk patients these days are in fact patients with high-grade T2 lesions. Endorectal MRI improves staging over digital rectal examination, but it's not widely available. Nomograms are very fashionable. They allow you to plug in PSA, Gleason score, clinical stage, and this gives you a chance of a certain pathological stage, the Parton tables, and estimated PSA recurrence following treatment with the Catan nomogram, which gives you a continuous expression of risk. And then there's the D'Amico classification, where there's more discrete risk categories. How do we select the appropriate local modality? This is quite important because the adequacy of local treatment does affect PSA recurrence rates. I think there are several potential advantages of surgery for high-risk disease over radiotherapy. At the risk of offending any radiation oncologists in the audience, I think that it provides excellent local control. We have the advantage of pathological examination of the specimen, and hence stratification of patients into risk categories in terms of who will benefit most from adjuvant treatment. PSA follow-up is obviously quite simple following surgery. The PSA should go to 0. Complete removal of the prostate reduces the likelihood of delayed dissemination of radioresistant cells. And there is the reduced toxicity of long-term androgen deprivation therapy. On the other hand, radiotherapy has a couple of advantages. Whole pelvic treatment is available, and there's no surgical morbidity, although no one will argue that there is certainly a morbidity from radiotherapy, which is not seen in surgery. The largest high-risk surgical series is that of Horst Zinke from the Mayo Clinic. Last year he published 15-year data on radical prostatectomy for T3 prostate cancer. Over 800 patients in the series with a median follow-up of 10 years. Interestingly, over a quarter of the patients were clinically overstaged, which supports the fact that I said earlier that digital rectal examination is not particularly good in assigning stage. And for those patients, for those 27%, monotherapy with just a radical prostatectomy is potentially curative, whereas had they entered a radiotherapy treatment scheme, they would have been committed to hormones for several years. The positive surgical margin rate was quite high at 56%, and positive lymph nodes were found in a quarter. When we compare the oncologic outcomes between the T2 and the T3 group, they're fairly similar actually. Overall survival is 53% versus 61%, and that's shown in the Kaplan-Meier curve to the right. They identified several factors which predicted for PSA recurrence. A lot of these are fairly standard: pathological grade, PSA, the non-diploid cells were cancers which were non-diploid had a higher chance of recurrence. positive surgical margin and seminal vesicle invasion. In terms of function, because they were a high-risk group, he excised neurovascular bundles bilaterally in most patients, and this resulted in no erectile function in the majority of patients. In terms of continence, at 1 year, there was a pretty similar continence rate between the two groups, and certainly complications were also similar. Locally, I've looked at the data from the series of high-risk patients that have been performed at Vancouver General Hospital, and we defined high risk as a PSA greater than 20, or biopsy Gleason score greater than 7, or clinical stage T3. There are 152 men, median age 63 years. A third had a PSA greater than 20, 2/3 Gleason greater than 7, and 20% clinical stage T3. Most patients, 79%, had just one preoperative risk factor, putting them in the high risk category, although 18% had 2 and just 3% all 3. The median follow-up was 3.3 years. Most patients received neoadjuvant hormonal therapy, 83%, and for most patients this was just androgen deprivation over usually around 8 months. However, there are 2 clinical trials which were run during that time, the OGX-011 trial and a trial of neoadjuvant docetaxel, and 21 patients participated in those trials. In terms of surgical pathology, 49% were organ confined, 29% non-organ confined. Surgical margin rate was 27%, positive surgical margin rate. PSA recurrence rate, the overall rate was 41%, and it occurred at a median of 21 months post-surgery. According to risk factor, one risk factor was associated with a lower chance of PSA recurrence compared to 2 or 3, which is not surprising. The risk of PSA recurrence increased with clinical stage. Pathological stage, there was a large difference between organ-confined disease and non-specimen confined disease and non-organ confined disease in terms of PSA recurrence, 22% versus 60%. And when we look at overall biochemical recurrence-free survival at 5 years, it's around 50%. And I've compared this to the series from MSK. Their 5-year biochemical free survival rate is 65%, but it's a slightly lower risk group in that patients with clinical stage T2C disease were included in the high risk category. 20 patients received salvage radiotherapy of this group. 6 have had a PSA relapse, and 5 are unable to be assessed for recurrence due to castrate testosterone levels. And after I accounted for salvage radiotherapy, that left 64% with no biochemical evidence of disease after a median follow-up of 3.3 years. So reasonable results. How can we improve surgical outcomes from a technical point of view? Pelvic lymph node dissection in prostate cancer has long been considered a staging procedure only. We know that removal of lymph node metastases from several other solid cancers influences disease progression. A lymph node dissection is often omitted in low-risk disease because of stage migration, which has occurred over the past 20 years. We're not seeing very many patients with positive lymph nodes anymore. In the 70s and 80s, the positive lymph node rate was up around 30%, and now it's less than 5%. The standard pelvic lymph node dissection involves removing the tissue between the external iliac vein and the obturator nerve, between the iliac bifurcation and the inguinal ligament. And this recovers about 9 lymph nodes. Dr. Studer from the University of Bern in Switzerland performed a prospective trial of 365 patients, and these patients all had an extended lymph node dissection, so removing tissue anterior to the obturator nerve, posterior to the obturator nerve, down to the pelvic floor, and including the lymph nodes along the internal iliac vessels. And the median number of lymph nodes recovered when that sort of dissection was done was 21. A quarter of the patients had positive nodes, which sounds pretty high, but this series was not your typical North American series. In fact, 70% of the patients were greater than pathological stage T3, so a reasonably high risk series. The rate of positive lymph nodes increased with the extent of local disease, so that for pathological stage T2 disease it was as low as 13%, but up around 50% once PT3 disease was looked at. Where were the positive nodes? Well, the highlighted figures show the percentage of patients with positive lymph nodes just in that particular area. So around the external iliac vein, 13% had lymph nodes which were positive just there. The obturator fossa, 26%, and interestingly, around the internal iliac vessels, an area which is seldom dissected in the standard lymph node dissection, 19% of patients had a positive node there and no other positive nodes in the other places. So if we look at this study, we can probably conclude that the rate of lymph node involvement is probably understated. It seems as if the harder you look, the more positive lymph nodes you find, and maybe omitting dissection along the internal iliac chain results in underrepresentative staging. Dr. Studer followed the patients who had positive lymph nodes from that original series. There are 88 patients, and looked at time to PSA relapse and disease progression and related it to the number of positive lymph nodes which were recovered. If there was just one positive lymph node, 39% remained disease-free. Greater than one, the results weren't quite as good, down to 10%, 10 to 14%. The time to serum PSA relapse was significantly lower in patients with just one lymph node, and cancer-specific survival was also better. And so he raised the question of whether doing a pelvic lymph node dissection was in fact therapeutic for patients with micrometastatic disease. However, from a study like that, you really have to say that lead time bias can't be discounted, and maybe we're just seeing the natural history of a micrometastatic disease. And until this is answered, maybe we should be doing an extended dissection in high-risk disease because it may provide a therapeutic benefit for that percentage of patients who have micrometastatic disease. How can we modify our surgical technique? Oncologic and functional outcomes are directly related to three variables in most cancer surgery. There's two modifiable factors, surgeon expertise and technique, and the fixed factors are the disease factors, the grade, the stage, the PSA. Surgeon expertise is well known to affect outcome. This is a study published in the New England Journal. Over 400,000 patients included in the study. It was from the Medicare claims database in the US, and they looked at the relationship between surgeon volume and operative mortality for several cardiovascular and cancer procedures, and found that the relationship between volume and mortality was maintained across all of these high-risk procedures. Surgeon volume has been shown to relate to function after surgery. Peter Scardino published this paper in the New England Journal from the SEER database, which showed that urinary complications and post-operative complications were related to surgeon and hospital volume. Volume and oncologic outcome. Well, this is local data from a Canada-wide study of 3 versus 8 months of neoadjuvant hormonal ablation. And as you can see, for the high volume centres, the PSA recurrence-free survival is better, and there was no difference in baseline prognostic factors which could account for the difference. So for high-risk disease, where the stakes are higher, it probably does matter where you have your surgery done and who does it. Technique. The aim of a radical prostatectomy is to avoid positive surgical margins with acceptable functional morbidity. and that's a pretty narrow line to walk sometimes. Positive surgical margins matter. The biochemical recurrence rates are much higher with positive surgical margins, especially if they're extensive. And if a positive surgical margin occurs in association with extracapsular disease, the prognosis is even worse. Most positive margins occur around the apex and in the region of the posterolateral pedicles. And for that reason, excision of a generous amount of tissue around the prostate in these areas will be associated with a lower positive margin rate in high-risk disease. Several techniques have been recommended in the literature to help us reduce the positive surgical margin rates. Most of them are pretty intuitive. Control of bleeding and maximum exposure to improve visualization is pretty obvious. Division of the prostatic pillars that tether the apex allows for good identification of the distal extent of the apex, which is often not obvious when you're looking from anteriorly because of that notch of tissue which sometimes extends behind the urethra. Recto-urethralis needs to be completely divided to enable you to enter that correct posterior plane and thus avoid a positive margin posteriorly. In high-risk disease, generally we resect the neurovascular bundles. Eric Klein suggested that a complete seminal vesiculectomy may be beneficial, and maybe we should be avoiding a laparoscopic approach, at least presently. The positive surgical margin rate for PT3 disease at MSK has recently been published, pretty low at 17.2% for 500 cases. Those are the world's leaders doing that. For the three largest laparoscopic series, the positive surgical margin rate for high-risk disease is around 30%. And in smaller series, it's up as high as 60%. So technical expertise and experience, particularly with laparoscopic surgery, it certainly impacts on positive surgical margin rates. This is a paper published in the British Journal of Urology last year from Florence in Italy. They looked at 84 patients who had an anterograde radical prostatectomy. So the bladder was disconnected from the prostate at the beginning of the operation rather than at the end. I'll just quickly go through the steps of the surgery here as they describe it. The endopelvic fascia is opened, dorsal venous complex tied but not divided. You divide the bladder neck, as shown here. Identify the vas deferens behind the bladder neck. Dissect out the seminal vesicles, and then open Denon-Villiers fascia and bluntly create the plane anterior to the rectum here, down to the level of the apex. And then the neurovascular bundles and the pedicles are divided. Finally, the dorsal venous complex is taken, and then the apex is inspected, and this allows for a pretty easily mobile prostate and easy inspection of the apex and division of the urethra at the appropriate level. The positive surgical margin rate was 13% for these relatively high-risk patients. What about multimodal approaches? Multimodal approaches refer to neoadjuvant and adjuvant systemic therapy or adjuvant radiotherapy. We've seen an improvement in outcome from surgery over the recent years through earlier identification of high-risk patients and surgical technique improvements. But the improvement that we can expect from surgical modification of technique is probably plateauing. And in order to improve disease control for high-risk disease, we need to employ multimodal strategies. Monotherapy is not adequate for high-risk disease. I'm going to review the evidence for neoadjuvant therapy now. Is there a role for neoadjuvant hormonal therapy? Well, there are several reasons to be enthusiastic about neoadjuvant therapy. The theoretical basis for the treatment was that androgens nourish the prostate, and we take these away, maybe the cancer will shrink away and improve outcome. Animal studies were quite promising. The survival benefit was shown. And the clinical observations, which go back many years, there's a benefit in metastatic disease, and we know there's a local tumour response to castration. So all of those things look pretty promising, but does it work? Of the early studies were non-randomized. 3 months of neoadjuvant therapy showed beneficial pathologic effects. This led on to phase 3 randomized studies, 3 versus 0 months of neoadjuvant treatment. The positive surgical margin rate decreased. To determine the optimum length of neoadjuvant therapy, a phase 2 trial of 8 months of neoadjuvant hormonal therapy was completed and showed that longer therapy was associated with a lower PSA nadir and lower surgical margin rates. A phase 3 multi-centre study of 3 versus 8 months of neoadjuvant treatment again showed that positive surgical margin rates were reduced, especially in the 8-month group. But unfortunately, there was no significant difference in PSA recurrence rates at 5 years for the study as a whole. However, on subgroup analysis, when we looked at the patients who were operated on in high-volume centres, there was a benefit in PSA recurrence seen in the intermediate-risk patients. What about neoadjuvant chemotherapy? The SWOG and TAX studies of docetaxel have shown a several-month survival advantage in patients with metastatic hormone-refractory prostate cancer. Well, what if we shift the chemotherapy to an earlier time and give it to patients before they have their surgery? Is there a benefit to doing this? Phase 2 trials of chemotherapy are designed to assess safety and feasibility. And one of the largest trials of neoadjuvant chemotherapy is in fact run through this centre. In summary, chemotherapy is generally pretty well tolerated. Extremustine-based regimes increase the toxicity of therapy without adding much. The toxicity is related to deep venous thrombosis and pulmonary emboli. In terms of oncologic efficacy, there is a biochemical response with chemotherapy alone, which supports the anti-tumour activity of chemotherapy. In terms of pathologic response, when we look at the prostate after it's been removed, marked tumour regression is seen in some patients, but a complete response where no cancer is detected is seen in very few. There is a large phase 3 neoadjuvant surgical trial which is currently accruing, the CALGB trial, 750 men randomized to 6 cycles of chemotherapy prior to radical prostatectomy. Unfortunately, extremustine is part of the cocktail which they receive, and because they are taking extremustine, the patients have also given warfarin to reduce their thrombotic risk. So this should give us an idea of the efficacy of neoadjuvant chemotherapy for high-risk disease. Adjuvant therapy has several advantages. It confines the morbidity of therapy to patients at high risk of relapse based on the most accurate measurement of risk that we have, and this is pathological assessment of a surgical specimen. On the downside, systemic therapy is delayed if micrometastatic disease is present. Adjuvant radiotherapy. There have been 3 randomized trials which have evaluated adjuvant radiotherapy. The 2 large ones are the SWOG trial and the EORTC trial of over 1,000 patients. The EORTC trial, patients were eligible if they had 1 or more adverse risk factors: capsular perforation, a positive margin, or seminal vesicle invasion. And they were randomized to conventional radiotherapy, 60 grays over 6 weeks, or a wait-and-see approach. And the primary endpoint was PSA recurrence. The Kaplan-Meier survival curves here show that there is a benefit in terms of biochemical progression-free survival and clinical progression-free survival for the radiotherapy group. And the treatment is pretty well tolerated. Grade 3 or higher toxicity is quite uncommon, although it's slightly higher in the radiotherapy group. The SWOG study looked at radiotherapy for PT3 disease, the biochemical recurrence-free survival at 5 and 10 years was better than that in the observation arm. In terms of overall survival, there was no difference at 5 years, but 5 years is not a particularly long time in prostate cancer, but there was a trend to improved survival at 10 years for the radiotherapy arm. The time to hormonal treatment was also delayed in the radiotherapy arm for men who failed adjuvant radiotherapy. So in summary, the risk of PSA recurrence for adjuvant radiotherapy is reduced by around 20 to 30% at 5 to 10 years if there are poor prognostic factors present on the surgical specimen. It's pretty well tolerated and should be considered if adverse pathology is present, especially if a positive margin is present. We don't have a survival advantage yet, but if we keep following these studies, it's probably going to show that there will be a survival advantage. The question that I have is it superior to salvage radiotherapy for those that recur? Well, the treatment's given very early, so it makes sense that it may be superior to salvage radiotherapy, but we don't really know the answer to that yet. Adjuvant hormonal therapy, the premise behind this is that by withdrawing testosterone, the cells which have already escaped from the prostate will die if testosterone is ablated. It's supported by trials of adjuvant tamoxifen in another hormone-sensitive cancer, breast cancer, and we know that adjuvant androgen ablation following radiotherapy is associated with a survival advantage in prostate cancer. There have been 4 trials of adjuvant hormonal therapy post-radical prostatectomy. 2 of them looked at adjuvant LH-RH agonists, and 2 of them looked at non-steroidal antiandrogens. The most familiar study to urologists is probably the Messing study, an ECOG study of 98 men with no positive disease, post-radical prostatectomy, and a survival advantage was shown for early hormonal therapy in these people. For adjuvant non-steroidal antiandrogens, the largest trial is the Bicalutamide EPC Trial. This is the Messing data. As I've said, immediate adjuvant hormonal therapy improves survival and no positive disease. The EPC study, bicalutamide 150 milligrams a day for localized or locally advanced cancer, is the largest trial of hormonal therapy in the world. There were 3 arms, a North American arm, a Scandinavian arm, and an arm which comprised countries from Europe, South America, Australia and Mexico. In total, over 8,000 men were included in the study, and around a third of them were higher risk. They were randomized to bicalutamide plus standard of care or placebo. And the primary endpoints were progression-free survival and overall survival. The latest data update from this trial came out in the BJU last year, 7.4 years of follow-up, and for localized disease, there's been no benefit shown to adjuvant bicalutamide. And in fact, there's a trend towards decreased survival in the watchful waiting group. For locally advanced disease, progression-free survival improved in all groups, watchful waiting, radiotherapy and radical prostatectomy. The benefit was most pronounced in the radiotherapy group. Overall survival improved in the radiotherapy group, a trend to improved survival in watchful waiters. But for the prostatectomy subgroup, there was no survival difference found. So what is the clinical utility of adjuvant hormonal therapy? Well, for node-positive disease, there is a benefit. But for prostate cancer patients who have a radical prostatectomy, there's not a lot of data to support adjuvant hormonal therapy outside of the node-positive group. Adjuvant chemotherapy. 2 small randomized trials of adjuvant chemotherapy post-radical prostatectomy for high-risk disease have been performed. Schmidt in 1993 compared cyclophosphamide to extramusting phosphate in 184 patients and found an improvement in recurrence-free survival in the extramusting group. This study wasn't powered to detect a survival difference. The other study from Hammersmith Hospital in England is quite small. Most of the patients, in fact, had metastatic disease, although there was a subgroup with advanced prostate cancer which was non-metastatic. And amongst those men, there was a survival advantage shown from adjuvant mitoxantrone. There are 3 planned or ongoing phase 3 trials of adjuvant chemotherapy for high-risk disease, looking at mitoxantrone and docetaxel. And these are large studies, one of which is powered to detect overall survival, and hopefully the answer will come from these phase 3 studies as to the oncologic benefit of adjuvant chemotherapy for the high-risk group. So in the future, I think we need to try and match the disease threat posed by prostate cancer, the spectrum from low to high risk, to the treatment intensity. There's certainly a morbidity to multimodal therapy, which patients with lower risk disease may not want to accept. We heard last week about the battle for prostate cancer and how it's going to be won and lost in the treatment of higher risk disease. This is true. So in the future we'll be able to better characterise the disease threat posed by high risk by prostate cancer, by PSA kinetics and molecular characterisation, divide our patients into lower and higher risk groups, and for the lower risk groups, hopefully minimally invasive treatments, even focal therapy could be employed, and for the higher risk patients, multimodal approaches with the backing of data from phase 3 studies of neoadjuvant and adjuvant therapy will allow us to better define the efficacy of adjuvant and neoadjuvant therapy. I haven't mentioned the work done here by Dr. Gleave at the lab. We heard about that 2 weeks ago, so I'll let him leave that to him, I think. So that's it. Thank you.